Sir, your video is not visible. Hello and welcome everyone. Thank you for joining today's session on your favorite channel, Cancer Reach. Cancer Reach is an initiative by our very own onco savior, Dr. Krishnamani, to spread awareness about cancer and to help patients and caregivers to access the right treatment at the right time. Today, we're shedding light on an often overlooked but rapidly growing health concern, that is advanced hepatocellular carcinoma, or more commonly known as the advanced liver cancer. This is the most common type of primary liver cancer, and it is becoming increasingly common around the world due to rising liver diseases like hepatitis and fatty liver disease. Without much further ado, let me begin by introducing our doctor to you. Dr. Krishnamani has been associated with AOI hospitals here in Hyderabad since more than a decade now. He has extensive expertise in managing a wide range of cancers, including both solid and hematological malignancies. Throughout his career, he has been an integral part of various hospitals and organizations across India, earning recognition as one of the country's leading oncologists. In addition to his clinical practice, Dr. Krishnamani has a deep interest in research and has participated in multiple clinical trials. He has served as the advisory board for clinical research. His commitment to advancing the field of oncology is further demonstrated by his membership in American and European oncology societies. Hello and welcome to you, sir.
Good evening. Welcome everyone to Cancer Reach. Cancer Reach is an initiative to spread awareness about cancer. And as you said, today we are going to discuss about advanced hepatocellular carcinoma, or HCC as we call it commonly, or to put it in very simple terms, liver cancer or primary liver cancer.
So, sir, since you have explained what is hepatocellular carcinoma, can you tell us what are the causes or what are the risk factors associated with this type of cancer?
So firstly, what we should understand as lay people is cancer in the liver is not liver cancer or primary liver cancer. Okay, so excuse me. The commonest cause of cancer in the liver is secondaries. Secondaries means you have a cancer elsewhere and that has spread to the liver. Which are the common cancers that go to the liver? Breast cancer, lung cancer, stomach cancer, colorectal cancer. So these are all cancers which start in breast, lung, colon, rectum, stomach, gallbladder. They have gone to the liver. This is not primary liver cancer. This is secondaries or metastasis. But the cancer which starts in the liver itself, which is not there elsewhere, that is your primary liver cancer or HCC, hepatocellular carcinoma. So number one is that distinction. Now, what are the causes of HCC? The commonest cause is alcohol. Other common causes are hepatitis B, hepatitis C. So chronic alcoholism, chronic hepatitis B, hepatitis C infections, what happens is they damage the liver in stages. The first stage is called fatty liver. The second phase is called hepatitis. The third phase is called cirrhosis or fibrosis. So chronic drinking or chronic infections, they go and damage the liver. There is fat deposition called fatty liver. This is reversible. You can still get away from this. The next stage is hepatitis. There is a lot of inflammation in the liver. Finally, it goes to an irreversible stage called cirrhosis. Cirrhosis means the liver gets shrunken. The smooth contour of the liver becomes irregular. And then you have other problems in the form of hypertension in the portal vein, portal hypertension, we say. Patients may present with ascites, that is water in the abdomen, which requires removal. They may present with bleeding in vomit, called varices. So these are all the complications of cirrhosis. And finally, in a cirrhotic liver, you develop hepatocellular carcinoma. Those nodules become cancerous. So the commonest causes are alcoholism, chronic hepatitis B and C, and now we see a lot of patients with NAFLD, non-alcoholic fatty liver disease. These are the patients who are very fat, who are obese, who have metabolic syndrome, diabetes, hypertension, cholesterol, triglycerides. So they don't have alcohol consumption, but they are called non-alcoholic fatty liver disease. When you have all this, it damages the liver in a stepwise fashion, causes HCC. There are other rare causes of hepatocellular carcinoma, like enzyme deficiencies, Wilson's disease, we say, iron overload, copper problems like ceruloplasmin deficiencies. So the alpha 1 antitrypsin, there's an enzyme. So these deficiencies can also lead to cirrhosis and lead to liver cancer. But from a public health perspective, no alcohol, that is good. Vaccination against hepatitis B to prevent hepatitis B infection. Do not indulge in high risk behavior like drugs, needles, using the same needles again and again, blood transfusions. What do you call that? They are called professional donors. Okay, people who donate for the sake of money. So they are at the risk of hepatitis B, C, and then you also get a whole gamut of problems with that. So commonest causes are these, and these are the public health precautions we have to take. Stop alcohol, take vaccination for hepatitis B. If you are hepatitis B positive, please take the drugs for hepatitis B after consulting your gastroenterologist. Then what will happen is you will reduce the viral load in your body. The viral load is reduced. The chances of it going into cirrhosis and HCC is minimized.
Sir, what can you tell us about the disease prevalence among the various age groups which are present, and also about the prevalence between the two genders?
Men are more common than women because of the high risk behavior in the form of alcoholism, etc. Non-alcoholic fatty liver disease also is slightly more common in men compared to women. Epidemiology, you say HCC is a disease of the elderly. Okay, you start the disease after 50 years or so. Why I tell you? If somebody has chronic hepatitis B or C, imagine a newborn has got infected by hepatitis B virus from its mother during delivery. The chances of that child getting into cirrhosis will happen only after 25, 30 years or 20, 25 years. So it takes the virus 20 years or 30 years to replicate in your body to damage your liver. After that, after another 5 to 15 years, you will probably develop liver cancer. So there is a long period to develop cancer here. So that is why this is usually a disease of the elderly, above 50. You don't get to see primary HCCs at much younger age.
What are the telltale symptoms for this disease that an individual can look out for?
See, they're very, very non-specific in the form of you can have weight loss, cachexia. Somebody may say you're looking like skin and bone. You've lost lot of muscle mass. Appetite goes down. Early satiety. You eat little, you feel fullness. Water in the tummy, abdomen, ascites, what we call. Your legs get swollen. Developing jaundice, bleeding in your vomit, okay, or bleeding per stool, black stools. These are all some of the symptoms which come in hepatocellular carcinoma, but they are also seen in cirrhosis. So basically, these are all symptoms of liver injury. And once you have these, you will be evaluated, and imaging or tests will detect that you have a liver cancer.
Sir, how does one diagnose liver cancer in a patient?
See, diagnosis is always based on first symptoms. So somebody with all the above mentioned symptoms. One of the important blood tests which is done is called alpha fetoprotein. Okay, it's a blood test. It's a protein which is elevated in liver cancers, but it can be elevated in hepatitis also, cirrhosis also, in other cancers also. So, or it can be normal also. So it doesn't mean if it is normal, you don't have HCC, or if it is high, it is 100% HCC. Another blood test is PUCA, we say, which is more sensitive than alpha fetoprotein. If you have normal alpha fetoprotein and elevated PUCA, it is more, it tends to go more towards HCC. So you will look at the symptoms with a background of hepatitis or cirrhosis with some risk factors, raised alpha fetoprotein or PUCA levels, and the scan is done. Usually, you start with an ultrasound, but one of the best scans for liver cancer is a triphasic CT abdomen. In a triphasic scan, what happens is you scan in the arterial phase, venous, and venous phase. So, what happens is the classical teaching is the tumor which appears on the scan, it enhances in arterial phase and there is a washout in the venous phase. This is the classical teaching. This is completely radiological. Laymen may not understand. It is not required also for us. What we should understand is we will do a triphasic CT scan, which is a CT scan, and we look at those points where there is enhancement arterially and venous washout. If this is enough for us to diagnose somebody with cirrhosis with raised alpha fetoprotein and classical imaging of triphasic scan, you don't need a biopsy to diagnose HCC. But in some case, when there is a doubt, when alpha fetoprotein is normal, when there is no cirrhosis in the background, sometimes you can have a mixed HCC and cholangiocarcinoma. That's a bile duct cancer. Both these can be involved together. So those are the conditions you will say, okay, let us do a biopsy. So these are the ways with which you come to a diagnosis of HCC.
So, sir, when you talk about primary liver cancer and you talk about secondary liver cancer, the diagnostic tests for both are going to be the same.
No. For example, for a breast or lung cancer, you will do a PET CT scan. You will not do a triphasic CT. There, 100% you need to do a biopsy. Here, you need not do a biopsy in all cases. There, you don't need an alpha fetoprotein. In liver cancer, primary HCC, you need an alpha fetoprotein or PUCA. There, background hepatitis, cirrhosis, nothing is there. Here, you have all that. For a breast cancer, you will do IHC, ERP or HER2. For lung cancer, you will do molecular panel, EGFR, ALK, PDL1, ROS, etc. All that will not be done in primary liver cancer. In primary liver cancer, there is no role of your ER, PR, HER2, EGFR, PDL1, etc.
Okay.
So they are completely different.
Okay, sir. Now, moving to the treatment part of it, how do you treat a patient with hepatocellular carcinoma?
So being a medical oncologist, we will let us, what do you say, curtail ourselves in today's discussion to advanced HCC. The early intermediate HCC, we will keep it for another session. Okay, so most patients present in an advanced phase. Advanced means what? There are multiple tumors in the liver. It has reached both the lobes, right lobe and left lobe. Lymph nodes are involved. It has spread beyond the liver. So go from outside to inside. The disease has spread outside the liver. The disease has spread to nodes. The disease has spread to both lobes. There are multiple lesions in the liver, and they cannot be treated with surgery or transplant or local treatments like TACE tear. TACE tear means trans-arterial chemoembolization or radioembolization. You will go inside the hepatic artery and do local treatment in the liver. So these tumors cannot be treated locally. They have spread beyond the liver to lymph nodes and they are in both the sides. That means advanced HCC. So how do you treat advanced HCC is the whole point. Most important things are two. What is the general condition of the patient? We call that performance status. We have discussed it multiple times. Second is what is the liver status, which is there are multiple scoring systems like the child puke criteria, the BCLC criteria, etc. So basically, you are looking at the liver health also. So If I give you an example of child puke criteria, you look at 5 parameters. Does somebody have water in the abdomen? Ascites. Does somebody have encephalopathy? That is, the brain is knocked off due to the liver. What is the prothrombin time value? What is the albumin value? What is the bilirubin value? Based on these 5 parameters, we will divide a person into child puke A, child puke B, child puke C. Imagine somebody is deeply jaundiced. His bilirubin is high. His albumin is very, very low. His prothrombin time is very high. These are all blood tests. He has lot of water in the tummy, ascites, and he's in deep coma. This fellow will be in child puke C. Child puke C means his liver is horrible. You should not give him any treatment for the liver cancer. He is eligible for best supportive care. Just leave him alone, keep him comfortable. Imagine somebody's liver is very good, child puke A. He is conscious like you and me. There is no encephalopathy, there is no ascites, bilirubin, albumin, prothrombin time are all normal. You will say you have child puke A. Somebody in between is child puke B. So child puke A patients and a few child puke B patients can only be treated. Only those should be treated. Child puke C should not be treated. Now, what's the treatment? Advanced HCC, is there any role for chemotherapy? No. So I will go through the very quickly. I'll tell you what treatments we have given in the last 15 years. When I was a resident, there was a drug called sorafenib. There is a tablet. It is called TKI, tyrosine kinase inhibitor. It helped in improving the survival of patients. It will cost you 3,000, 4,000 per month. It has some side effects in the form of mouth ulcers, diarrhea, blood pressure rise, your palms and soles becoming, dry and all that. Next, after a few years, we found another drug called lenvatinib. Sorafenib got its bigger brother, lenvatinib. That is better than sorafenib. That also can cause hypertension, diarrhea, mouth ulcers. So we ask people to gargle their mouth, etc., maintain a blood pressure check and all that. The last 5 years, we have come to the immunotherapy and targeted therapy era. So there are two drugs in that. One is immuno-targeted combination. One is immuno-immuno combination. So the immuno-targeted is atezolizumab plus bevacizumab. Atezo is immuno, bevacizumab is targeted. Both are injections given over 1 to 2 hours, once every 3 weeks in an IV line. So this drug was superior to sorafenib. Problem is, anybody who has varices, bleeding, they should not be given this drug, or they should be at least 6 months free from this variceal bleeding, or they should have had what we call banding, etc. So somebody who is constantly vomiting blood or untreated varices, don't go for atezobeva. But it's a good drug. It has shown benefit. How long you will give? Till the scan is good or the patient is good. Till the patient is getting benefit, you have to continue. So sorafenib was the oldest drug. Then came lenvatinib. Now you have atezobeva, which is immuno-targeted. Once every 3 weeks in an IV line, 2-3 hours injection both together. If you have varices or don't give this drug, if the varices have been treated for at least 6 months, then you can go ahead with this drug. Bleeding is a risk. Hypertension is a risk with this treatment, and it has shown benefit. And till when will you give? There is no fixed stopping for this. So till you are getting benefit, till your scans are good and your scan disease is under control, continue. Now the latest treatment is immuno combination, which is called tremelimumab plus durvalumab. This is once every 4 weeks. So this is 3 weeks. So this is longer. One more week the patient gets. This can be used in patients who have varices also, who have bleeding also. There is no contraindication like that. Okay, so these are the options you have got. How do you choose between these? It's a matter of clinical judgment. If somebody has varices, I will go for Tremi Durva. Otherwise, I will go for Atazobev. If I need a quicker response, I will go for Atazobev. Okay, if somebody has little amount of disease only, I can probably go for double immuno combination. So this is the way you choose. But these two options are expensive in India. That is what we should understand. The cost goes in lakhs. So if patients can't afford, we go to lenvatinib, which is again cheaper, which will cost you less than 5 to 8,000 a month. You will keep scanning this patient at 4 to 6 month interval, keep doing alpha fetoprotein. If disease is under control, you will continue the drug. If disease increases, you have to change. If you gave atazobeva or double immuno before, go to lenvatinib. If you gave lenvatinib before, go to immunotherapy. That you have to interchange. Always understand, stop alcohol. Always understand, take your antivirals for hepatitis B. Without that, this treatment is useless. And if you have bleeding, varices, and all that, that requires banding and other kinds of treatment. And if you have ascites, periodically you may have to tap the fluid also so that you get symptomatic relief.
In general, how do the patients perform with this disease and after the treatment is being given to them?
So untreated HCC, the treatment prognosis is usually less than 6 months, 4 months or so. If you treat with these newer agents, survivals are going beyond 14 months to 16 months or so. But so overall, it's still a bad disease. Not everyone can get treated because most patients come with Child-Pugh B or C. Only those in A are eligible for treatment. Treatments are expensive. Prognosis is poor, 12 to 18 months as a ballpark figure.
And sir, this is the same situation for primary liver cancer as well as the secondary part, both which are advanced.
No, no. Imagine somebody has lung cancer, EGFR positive, spread to liver. He or she will survive beyond 5 to 6 years. Breast cancer, hormone pass positive, they will do wonderfully well beyond 5 years, 6 years.
Okay.
That is why whether you have primary or secondaries is the first step. It will tell your treatment, it will tell your diagnosis, it will tell your prognosis.
Okay. And sir, additionally, since majority of the patients would have had an experience with alcohol use or abuse in the past, is there any additional rehabilitation facilities which should be provided to those patients?
There are multiple places which are available now. Even on phone, people offer services for rehab, for counseling for our patients. They should utilize those kind of services and abstain from alcohol.
Okay, sir. Sir, a few myths to bust before we move on with the session. So the first one is that HCC only occurs in people who drink alcohol.
No, hepatitis B, hepatitis C, non-alcoholic fatty liver disease, and other rare causes also.
So the second myth is that surgery is not an option for advanced HCC patient.
Surgery is an option for early HCC patients. If it is single lesion or 2 or 3 lesions, if it is limited to one lobe of the liver, surgery is an option.
Okay. Chemotherapy is the standard treatment for advanced HCC.
No chemotherapy in HCC. It is tablets or TKI or immuno combination or immuno-targeted combination. No role of chemo.
Okay, sir. Sir, any last messages for the for our audience for today's session?
Yeah. So HCC is common in India. HCC can be prevented by abstaining from alcohol, hepatitis B, C, prevention or treatment, and having a good healthy lifestyle, diet, etc. to prevent non-alcoholic fatty liver disease. If detected early, surgery, transplant are options. We will discuss them at a different time point. Advanced HCC has a poor prognosis, but there are options available and they are not chemotherapy. They are newer options with lesser side effects. And hopefully, we just hope that it gets better and so that patients live longer.
So, sir, recently we came to know about you giving a second opinion for cancer patients. Can you please educate our audience about the same?
Correct. So our main fundamental on cancer reach is we want to reach as many people as possible and give them cancer related education. That could be laymen, that could be caregivers, that could be even medical students. Even they would be after today's talk, for example, even an MBBS student listens to this, at least he or she can know what drugs are being used and when they are being used. So ours is a very generalized way of giving cancer information. So on Cancer Reach, we also believe in providing a second opinion to patients. We have a number. Patients can WhatsApp on that. The second opinion, which is initially given, is completely free. So we have many people who log into us who send us WhatsApp messages, we try to maintain a turnaround time of less than 24 to 36 hours, and we reply them back saying these are all the things which have to be done. So the aim here is the patient could be anywhere in the country, but at least he or she can be given a direction by an oncologist, and then they can follow it up with their own oncologist whom they are seeing.
Okay, so I think this is a very, very good initiative and a much needed one in today's day and time. Thank you for giving us your time and thank you for educating us on advanced hepatocellular carcinoma. And we hope to see you again next Friday, sir.
Thank you
Thank you,
so
sir.
much. Bye.
Thank you, sir.